Hyperthyroidism is a biochemical diagnosis which occurs when there is pathologically increased thyroid hormone production and secretion by the thyroid gland. Thyrotoxicosis is the clinical manifestation of excess thyroid hormone action at the tissue level due to inappropriately high circulating thyroid hormone concentrations. Thyroid hormones are essential for normal growth, development, and cellular metabolism. Circulating thyroid hormone levels are normally controlled through the process of negative feedback on the hypothalamus and pituitary gland. The thyroid gland is located within the neck at the level of the C5 to T1 vertebrae. It consists of a central isthmus and two lobes. The gland sits anterior to the trachea with the four parathyroid glands, which lie on the posterior surface of the thyroid gland. Hypothalamic pituitary thyroid, HPT axis. The thyroid gland is stimulated and controlled by TSH from the anterior pituitary. TSH is released by thyrotropin-releasing hormone from the hypothalamus. The thyroid gland, in response to TSH, produces thyroxine T4 and triiodothyronine T3. Greater amounts of T4 are produced than T3. T4 is inactive and needs to be converted to T3, which occurs peripherally, such as in the liver and kidney. Most T3 and T4 in the circulation are bound to protein, mostly thyroglobulin. It is only free thyroid hormone that is active. Free thyroid hormones in the circulation act negatively on the hypothalamus and pituitary, thus reducing the release of TRH and TSH. Classification of hyperthyroidism can be in two ways: the location of abnormality and hormone levels. Primary hyperthyroidism occurs when thyrotoxicosis is caused by an abnormality of the thyroid gland, such as Graves' disease. Secondary hyperthyroidism occurs due to a pathology of the pituitary gland resulting in excess TSH. Classification via hormone levels. Overt primary hyperthyroidism is diagnosed when TSH is suppressed below the normal reference range, and FT4 and/or FT3 concentrations are above the normal reference range. Subclinical hyperthyroidism is diagnosed when TSH is suppressed below the normal reference range, but FT4 and FT3 concentrations are within the normal reference range. Thyrotoxicosis without hyperthyroidism describes thyrotoxicosis without thyroid gland overactivity, which is usually transient. Risk factors for developing hyperthyroidism include female gender. Women are 10 times more likely to develop hyperthyroidism than men. Women are more likely to develop Graves' disease. People with a history of other autoimmune disorders, those with a family history of thyroid or other autoimmune disorders, e.g., diabetes mellitus 1, Addison's disease, vitiligo, and smokers are at an increased risk of developing Graves' disease. Family history. Half of people with Graves' disease have a family history of thyroid disease. Smoking. Smoking is a dose-dependent risk factor for Graves' hyperthyroidism and Graves' orbitopathy. In addition, smoking is related to a higher recurrence rate of Graves' hyperthyroidism. Current smokers have a threefold increased risk of developing Graves' orbitopathy compared with non-smokers. Among people with confirmed Graves' orbitopathy, smokers are more likely to have severe disease compared with non-smokers, and are more likely to experience disease progression and poorer outcomes following treatment. If a person has Graves' disease, the most significant modifiable risk factor for developing Graves' orbitopathy is smoking. Autoimmune disease. Coexistent autoimmune conditions are a risk factor for developing Graves' orbitopathy, hyperthyroidism, and postpartum thyroiditis. The prevalence of postpartum thyroiditis is 3-4 times higher in women with type 1 diabetes mellitus compared with unselected populations. Low iodine intake. This may cause a multinodular or single nodular goiter and is likely to occur if iodine intake increases, either gradually through dietary changes or suddenly with the use of iodine-containing drugs, such as amiodarone. Highly active antiretroviral therapy, HART. Three gene regions consistently linked to Graves' hyperthyroidism are the human leukocyte antigen region, CTLA4 and PTPN22, all of which encode proteins that are involved in immune function and linked to the cause of other autoimmune disorders. Causes of thyrotoxicosis with hyperthyroidism: increased thyroid hormone synthesis. Thyroidal origin. 1. Graves' disease. This is the most common cause of hyperthyroidism in iodine-sufficient areas, accounting for about 80% of cases. It is a systemic autoimmune disorder mediated by thyroid-stimulating hormone TSH receptor antibodies, TRAbs, that stimulate the TS receptor, leading to thyroid hyperplasia and unregulated excessive production and secretion of thyroid hormone, resulting in hyperthyroidism and diffuse goiter. Peak incidence is at 30s, 50s years of age, and it is 10 times more common in women than men. Typical eye signs of Graves' orbitopathy occur in about 1/3 of cases. People with a personal or family history of autoimmune disorders, such as type 1 diabetes mellitus, are at increased risk. Some patients have pretibial myxedema called thyroid dermopathy, as can occur anywhere, particularly following trauma. This is usually associated with moderate to severe ophthalmopathy. 10–20% have clubbing thyroid acropathy. 2. Toxic multinodular goiter. This is the second most common cause of hyperthyroidism in the UK and is more common in older adults, over 60 years. It occurs in a thyroid gland with at least 2 autonomously functioning thyroid nodules that secrete excess thyroid hormone histologically. The nodules are benign follicular adenomas. People over 60 years of age and people living in iodine-deficient areas such as Denmark are at increased risk, as thyroid autonomy develops after a long period of low iodine intake. 3. Toxic thyroid nodule adenoma. This accounts for up to 5% of cases of hyperthyroidism and is more common in older adults. The nodule produces enough hormone to suppress secretion of TSH from the pituitary, with consequent suppression of the contralateral thyroid lobe. Histologically, the nodule is a benign follicular adenoma. Extrathyroidal origin. Pituitary. 4. TS-secreting pituitary adenoma. This is a rare tumor secreting large quantities of TSH, leading to inappropriately normal or elevated TSH levels, with elevated free thyroxine FT4 and total triiodothyronine T3 levels. The pituitary does not respond to normal T4 and T feedback mechanisms. 5. Pituitary thyroid hormone resistance syndrome. This is a rare condition caused by genetic mutations in the thyroid hormone receptor beta gene. A positive family history supports the diagnosis. Usually the person is euthyroid, but thyrotoxic symptoms may occur. 6. Struma ovarii. This describes ectopic thyroid hormone secretion from thyroid tissue located in an ovarian teratoma. 7. Functional thyroid cancer metastases. These can result in extrathyroidal foci of thyroid hormone production. High concentrations of human chorionic gonadotrophin, HCG, can stimulate TSH receptors and suppress TSH. 8. Gestational thyrotoxicosis. This is a benign and transient disorder typically seen in the first trimester of pregnancy, caused by the stimulatory action of placental beta-HCG. There is an absence of thyroid autoimmunity, and it does not require any specialist treatment. Hyperemesis gravidarum, defined as 5% weight loss of pre-pregnancy weight, dehydration, and ketonuria. 9. Chorionic gonadotrophin-secreting tumors, such as choriocarcinoma or hydatidiform mole. Tumor produces beta-HCG, which stimulates thyroid TS receptors. Iodine excess. 10. Iodine may suppress TS levels and is found in over-the-counter preparations, such as kelp supplements. 11. Amiodarone-induced thyrotoxicosis, AAT type 1. If a person with underlying thyroid disease is exposed to the high iodine content of amiodarone, this may lead to excess thyroid hormone synthesis and release the long half-life of amiodarone, may cause hyperthyroidism for up to 1 year after it is discontinued. 12. Iodinated radiographic contrast agents may suppress TSH levels. Causes of thyrotoxicosis. Without hyperthyroidism, increased availability of preformed thyroid hormone. Thyroid origin. Thyroiditis causes a usually transient release of preformed thyroid hormones into the circulation due to inflammatory destruction of the thyroid follicles and includes 1. Postpartum thyroiditis, BPTT. Postpartum thyroiditis presents with the transient acute phase of thyrotoxicosis, followed by a period of hypothyroidism. This can occur 2 to 6 months following birth or miscarriage. This is a painless, inflammatory autoimmune condition. The immune system normally falls in pregnancy for safety of baby. It is defined as the development of thyrotoxicosis, hypothyroidism, or thyrotoxicosis, followed by hypothyroidism within a year of giving birth. In women who were euthyroid prior to pregnancy, most women become euthyroid within 12 months of delivery, but there is a 30% risk of permanent hypothyroidism. If thyroid peroxidase autoantibodies are positive in early pregnancy, there is a 40–60% chance of PPT developing. Treatment of PPT is with beta blockers. 2. Subacute eau de Crevon's thyroiditis typically presents with thyroid pain and fever, and is thought to be due to a viral infection or post-viral inflammatory process. Treatment is with steroids, NSAIDs, aspirin. 3. Amiodarone-induced thyrotoxicosis, AAT type 2, describes a destructive thyroiditis caused by the direct toxic effect of amiodarone on thyroid cells, usually self-limiting. Amiodarone-induced thyrotoxicosis is of 2 types. A type 2 is a destructive thyroiditis resulting in leakage of thyroid hormones. Radioactive iodine uptake is low because TSH is suppressed. Ultrasound gives a less vascular image. Amiodarone-induced thyrotoxicosis type 1 is also known as Jod-Basedow syndrome and is due to increased activity of thyroid, thus resulting in a vascular appearance on thyroid Doppler ultrasound. Stopping amiodarone is of little use because amiodarone gets stored in fat and has a long half-life. Treatment for both types 1 and 2 is with carbimazole and steroids. 4. Lithium rarely causes hyperthyroidism, and this may present more than 1 year after starting the drug. Antiretrovirals and cancer immunotherapy drugs such as interferon alpha can precipitate extrathyroidal origin. Excess intake of levothyroxine, LT4. In the UK, the most common cause of a serum TSH level less than 0.1. Excess use of LT4 medication may be intentional, factitious, or unintentional, iatrogenic. Thyroid hormone may also be a constituent of over-the-counter weight loss supplements. Complications of untreated or undertreated hyperthyroidism include Graves' orbitopathy. This is an autoimmune disorder, and in about 90% of cases, it occurs in people with a current or past history of Graves' disease. Sight-threatening complications include dysthyroid optic neuropathy, severe corneal exposure and ulceration, or corneal breakdown leading to frank perforation. It can affect a person's quality of life and psychosocial well-being due to possible distressing changes in facial appearance. Thyrotoxic crisis, thyroid storm. This is a rare and potentially life-threatening complication, which may occur after a trigger such as acute infection, trauma, pregnancy, surgery including thyroidectomy, or stroke. It may occur in people with previously undiagnosed hyperthyroidism, or those who have abruptly stopped antithyroid medication. Clinical features reflect systemic decompensation and include fever, tachycardia, agitation, hyperthermia, hypertension, atrial fibrillation, heart failure, jaundice, delirium, coma. Look for precipitating events, such as the withdrawal of an antithyroid drug, radioiodine therapy, infection and surgery. Management is with intravenous fluids, beta blockers, antithyroid drugs, and steroids. It is also important to look for the presence of Addison's disease in these patients. It has 20–30% mortality due to arrhythmias and hypothermia. Thyrotoxic periodic paralysis is a serious complication characterized by muscle paralysis and hypokalemia due to a massive intracellular shift of potassium. An annual incidence of up to 2% has been reported in Asian people with thyrotoxicosis, precipitated by alcohol, carbohydrate, and high salt intake. Compression symptoms: a large goiter may cause dysphagia or breathlessness due to esophageal or tracheal compression. Musculoskeletal thyrotoxic periodic paralysis. This is a rare complication characterized by muscle paralysis and hypokalemia, which is more prevalent in Asian people with hyperthyroidism, reduced bone mineral density, and osteoporosis. Overt hyperthyroidism is associated with an increased risk of osteoporosis and fracture. Do bone profile test. Increased mortality. There is an increased risk of death from all causes in people with hyperthyroidism and subclinical hyperthyroidism, including due to coronary heart disease. Mood disorders. Psychosis, rare, has been noted to complicate some cases of severe hyperthyroidism. Cardiovascular effects. Atrial fibrillation. A review article notes that people with hyperthyroidism over 60 years of age have a threefold increased risk of developing atrial fibrillation than euthyroid controls. The risk for developing atrial fibrillation increases with decreasing serum TSH levels, compared with euthyroid controls. The risk is also increased in older people. Heart failure. Atrial fibrillation is an independent predictor of the development of heart failure in people with hyperthyroidism. Premature atrial and ventricular beats and heart failure with preserved ejection fraction may be associated with severe subclinical hyperthyroidism. The American Thyroid Association (ATA) guidelines on hyperthyroidism note that the risk of atrial fibrillation is increased in people with subclinical hyperthyroidism who are older and have lower TSH levels. Effects on pregnancy. There is an increased risk of miscarriage, pregnancy-induced hypertension, maternal heart failure, preterm delivery, intrauterine growth restriction, low birth weight, and fetal death. Fetal complications of maternal hyperthyroidism include intrauterine growth restriction, fetal goiter, fetal hydrops and heart failure, fetal or neonatal thyrotoxicosis. Fetal or neonatal thyrotoxicosis may occur as a result of thyroid-stimulating hormone receptor antibodies, TRAbs, crossing the placenta in women with Graves' disease and stimulating the fetal thyroid. The incidence of fetal and neonatal hyperthyroidism is between 1–5% in all women with active or a past history of Graves' hyperthyroidism, and it is associated with an increased risk of fetal or neonatal morbidity and mortality if it is unrecognized and untreated. Ask in history. Any risk factors associated with hyperthyroidism, such as smoking history, medical history of autoimmune disorders, such as type 1 diabetes mellitus, Addison's disease, or vitiligo, recent viral infection, Crohn's thyroiditis, family history of thyroid disease, personal or family history of hypothalamic pituitary disease, medication history, use of amiodarone, levothyroxine, or recent use of contrast media, obstetric history, recent pregnancy or miscarriage. Suspect the thyrotoxic phase of postpartum thyroiditis, EPTT, typically between 1 to 6 months postpartum, which usually lasts only 1 to 2 months. Note: be aware that other conditions such as Graves' disease can also present postpartum. Any possible features of pituitary disease, such as history of brain or metastatic cancer, headache or visual field defects. Symptoms of thyrotoxicosis include rapid onset malaise, fever, and thyroid pain may suggest subacute thyroiditis. Compression symptoms of breathlessness, hoarse voice, dysphagia, neck pressure may be caused by a toxic multinodular goiter. Agitation, emotional lability, insomnia, irritability, anxiety, palpitations, exercise intolerance, fatigue, muscle weakness, heat intolerance, increased sweating, increased appetite with unintentional weight loss, diarrhea, subfertility, oligomenorrhea, amenorrhea, polyuria, thirst, generalized itch, reduced libido. Deterioration in blood glucose control and hyperglycemia in people with diabetes mellitus. Deterioration of comorbid heart disease, for example, in the elderly. Mental illness may range from anxiety to psychosis. Note that clinical symptoms and signs are typically absent, mild, or nonspecific in subclinical hyperthyroidism. If clinical features are present, they are more likely in younger people. Signs of thyrotoxicosis: agitation, fine tremor, warm, moist skin, palmar erythema, sinus tachycardia, atrial fibrillation, heart failure, peripheral edema, pruritus, urticaria, vitiligo, diffuse alopecia, muscle wasting, proximal myopathy, hyperreflexia, fine tremors, splenomegaly, lymphadenopathy, gynecomastia in men, hair thinning or diffuse alopecia. Examine the person for possible signs or complications of hyperthyroidism, including assessment of pulse, blood pressure, temperature, weight, signs of fluid overload or heart failure, thyroid enlargement, a goiter, and/or thyroid nodules, tenderness and symmetry. A hard and irregular goiter or nodule may indicate malignancy. Signs of Graves' disease. Signs of other autoimmune disease such as type 1 diabetes mellitus and vitiligo. Thyroid enlargement goiter. In Graves' disease, the thyroid gland is usually diffusely symmetrically enlarged without nodules, and there may be a bruit. A toxic multinodular goiter typically presents with non-tender thyroid nodules. A toxic adenoma typically presents with a unilateral, non-tender thyroid mass. Subacute thyroiditis typically presents with a tender, firm, irregular, diffusely enlarged thyroid gland, which may be asymmetrical. In amiodarone-induced thyroiditis, a small goiter is usually present. Extrathyroid manifestations of Graves' disease, rare. 1. Thyroid acropathy, clubbing and swelling of the distal fingers and toes. 2. Thyroid dermopathy, slightly pigmented, thickened skin and swelling of both legs, usually in the pertibial area. 3. Extrathyroid manifestations of Graves' disease, rare. 1. Thyroid acropathy, clubbing and swelling of the distal fingers and toes. 2. Thyroid dermopathy, slightly pigmented, thickened skin and swelling of both legs, usually in the pertibial area. 3. Graves' orbitopathy, if there are clinical features of eye irritation, photophobia, or excessive watering of the eyes, redness of the eyes or eyelids and/or lid swelling, change in the appearance of the eye or eyelids, eyelid retraction, sclera is visible above the superior corneal limbus, lid lag, delay in moving the eyelid as the eye moves downward, proptosis, exophthalmos, eyeball protrusion, and inability to fully close the eyes as the upper and lower lids do not fully oppose, persistent double vision in any direction of gaze, typically when looking upwards and outwards, unexplained deterioration in visual acuity, change in the intensity or quality of color vision in one or both eyes, orbital aching or restricted eye movements, suggests dysthyroid optic neuropathy. History of globe subluxation. One or both eyes suddenly popping out, typically lasts more than a few seconds, is painful, and the lids could not be closed. Investigations. Check the serum TSH level. If the TSH is within the reference range, further investigations are not usually needed, as hyperthyroidism is very unlikely. If the TSH level is below the normal reference range, the free thyroxine FT4 and free triiodothyronine F3 levels should be measured in the same sample. Suspect a diagnosis of overt hyperthyroidism if the TSH level is low and FT4 and/or FT3 levels are raised above the normal reference ranges. Suspect a diagnosis of subclinical hyperthyroidism if the TSH level is below the normal reference range and FT3 and FT4 levels are within the normal reference range. Repeat TFTs 3 months after the initial result to exclude other causes of a transiently suppressed TSH and to confirm the diagnosis. If on repeat testing there's a persistently low TSH level with normal FT4 and FT levels, the diagnosis is confirmed. Additional blood tests, depending on clinical judgment, such as TS receptor antibodies, TRAbs. If a diagnosis of Graves' disease is suspected or the person is pregnant, they have been shown to have a sensitivity of 98% and a specificity of 99%. Inflammatory markers such as erythrocyte sedimentation rate, ESR, and C-reactive protein, CRP. If a diagnosis of thyroiditis is suspected, thyroid peroxidase antibodies, TPOABs. If a woman is postpartum and a diagnosis of postpartum thyroiditis is suspected, baseline full blood count, FBC, and liver function tests, LFTs. If antithyroid drugs are to be started. Inflammatory markers. In patients with subacute thyroiditis, CRP and ESR are often raised. Arrange an ultrasound of the neck to image palpable thyroid enlargement or focal nodularity in adults with normal thyroid function if malignancy is suspected. Doppler ultrasound may be used to image the thyroid gland to confirm the presence of goiter and identify nodules. Interpreting thyroid function tests. When TSH is high and FT4 is normal, it is subclinical hypothyroidism. When both TSH and FT4 are elevated, it is pituitary adenoma, secondary hyperthyroidism. When TSH is high and FT4 is low, it is autoimmune thyroiditis, primary hypothyroidism. When TSH is normal and FT4 elevated, it is pituitary adenoma, secondary hyperthyroidism. When TSH is normal and FT4 is low, it is a non-secreting pituitary adenoma, secondary hypothyroidism. When TSH is low and FT4 is normal, it is subclinical hyperthyroidism. When TSH is suppressed and FT4 is high, it is primary hyperthyroidism, Graves' disease. When TSH is low and FT4 is low, it is secondary clinical hypothyroidism. Management of Graves' orbitopathy. Arrange emergency admission or seek immediate advice from an ophthalmologist with a special interest in thyroid eye disease. If a person has a suspected sight-threatening complication, such as dysthyroid optic neuropathy, suggested by deteriorating visual acuity or decreased color discrimination, history of globe subluxation, corneal exposure, cornea or sclera visible with the eyes closed, increasing the risk of corneal ulceration. Arrange a routine referral to an ophthalmologist with a special interest in thyroid eye disease, or a joint endocrinology and thyroid eye clinic if available. For all other people, note that this may include eye signs in a person who is euthyroid. Whilst awaiting specialist assessment, advise the person on smoking cessation, the use of artificial tears to lubricate the eyes, avoidance of irritation and damage to the eyes, for example using dark glasses, avoiding dust, and wearing eye protectors during sleep, elevating the head of the bed to relieve morning eyelid swelling. if needed. Provide advice on sources of information and support, such as the Thyroid Eye Disease Charitable Trust and the British Thyroid Foundation. Management person with subclinical hyperthyroidism, non-pregnant. Subclinical hyperthyroidism is of two types. Both have TRE and T4 normal. Subclinical hyperthyroidism occurs in around 2% of the elderly population. The most common cause of true subclinical hyperthyroidism is toxic nodular goiter, especially in the elderly. Look for secondary causes of low TSH with normal thyroid hormone levels, e.g., concomitant illness or medications, such as glucocorticoids, dopaminergic drugs, or amiodarone. Subclinical hyperthyroidism is of two types. Grade 1 has TSH in range 0.1 to 0.4. Grade 1 doesn't require treatment. Unless symptoms develop, it is usually just followed with hormone and antibody levels. Grade 2 has TSH less than 0.4. These patients should be treated as there is a higher chance of thyrotoxicosis. Subclinical hyperthyroidism is associated with increased risks of coronary heart disease, CHD mortality, and incident atrial fibrillation, with highest risks of CHD mortality and atrial fibrillation when thyrotropin level is lower than 0.10. It is also associated with an increased risk of hip and other fractures, particularly among those with TSH levels of less than 0.10. Arrange referral to an endocrinologist for specialist investigations and management if there are two thyroid-stimulating hormone readings lower than 0.1 at least 3 months apart, and there is evidence of thyroid disease, for example, a goiter or positive TSH receptor antibodies, or symptoms of thyrotoxicosis. Arrange an urgent referral using a suspected cancer pathway if a person has a goiter, nodule, or structural change in the thyroid gland, if malignancy is suspected. Note: TFTs are usually normal in people with thyroid cancer. If the decision is made to treat, radioiodine is generally the treatment of choice, especially in toxic nodular goiter. An alternative is long-term carbimazole. If untreated, check TSH every 6 months. Overt hyperthyroidism, non-pregnant management. Establish whether the patient needs urgent admission or management on an outpatient basis. Arrange emergency admission if there are symptoms suggesting a serious complication, such as thyrotoxic crisis. If a pituitary or hypothalamic disorder is suspected, depending on clinical judgment. If unwell or unable to manage at home. If there is presence of atrial fibrillation or cardiac failure. If there is dehydration, e.g., from severe diarrhea. If there is psychosis, while awaiting specialist endocrinology assessment. Consider prescribing a beta blocker, e.g., atenolol, and titrating the dose depending on clinical response. To provide relief of adrenergic symptoms, such as palpitations, tremor, tachycardia, or anxiety. If there is any uncertainty about starting a beta blocker in primary care, seek specialist advice. Adjust the beta blocker dose according to symptom response, and aim to taper and stop the drug once the person is asymptomatic and euthyroid. Calcium channel blockers may be used if patients are intolerant of beta blockers. Consider seeking specialist advice about starting antithyroid drugs such as carbimazole in primary care for people with troublesome symptoms despite treatment with a beta blocker, or if a beta blocker is not tolerated or contraindicated. Those who are at risk of a complication from hyperthyroidism. Those who are taking a drug treatment such as amiodarone or lithium. Liaison between the specialist prescribing the drug and an endocrinologist may be needed. Refer urgently to a thyroid surgeon. Hyperthyroid patients with a thyroid swelling associated with a solitary enlarging nodule, previous neck irradiation, family history of endocrine tumor, hoarseness or voice changes without other obvious cause, neck glands. Young age, before puberty. Older age, 65 or more, blood monitoring for people on carbimazole and propylthiouracil, or after radioactive iodine treatment or thyroid surgery, should be arranged by the person's endocrinologist, who should interpret the results to guide adjustments to the person's treatment regime, if appropriate. Treatment choices: antithyroid drug, carbimazole, methimazole, or propylthiouracil class thiamides. These drugs act very quickly and inhibit the production of thyroid hormones. Full benefit may take 2-3 weeks to become apparent. Antithyroid drug treatments, carbimazole and propylthiouracil, are used to decrease thyroid hormone synthesis by acting as a preferred substrate for iodination by thyroid peroxidase, the key enzyme in thyroid hormone production. Propylthiouracil is usually not used first line due to a small risk of severe liver injury, except in certain circumstances such as pre-pregnancy or the first trimester of pregnancy, or for specialist treatment of thyrotoxic crisis. It may be used second line if carbimazole is not tolerated. Antithyroid drugs should only be initiated on specialist advice and are typically used short-term to restore euthyroidism, for example in toxic nodular goiter, in preparation for definitive treatment with radioactive iodine treatment or thyroid surgery. Medium-term with the aim of inducing remission of Graves' disease. A person with newly diagnosed Graves' disease may be treated with antithyroid drugs for 12-18 months if there is mild and uncomplicated disease. Most people with Graves' disease become euthyroid after 4-8 weeks of treatment with carbimazole. People with severe hyperthyroidism, a large goiter or recent exposure to iodide, may need a longer duration of treatment. Long-term if radioactive iodine treatment or surgery is contraindicated or declined. Monitoring. Before starting treatment with carbimazole or propylthiouracil, full blood count, FBC, including white cell count and differential and liver function tests LFT-ATI should be checked. Do not monitor FBC and LFTs in people taking antithyroid drugs for hyperthyroidism unless there is a clinical suspicion of a granulocytosis or liver damage. Monitoring of antithyroid drug regimens, thyroid-stimulating hormone, THCA, free thyroxine, FT4, and free triiodothyronine, F3, should be checked every 6 weeks until the TSH is within the reference range. Then TSH, with cascading to check FT4 and FT3, every 3 months until antithyroid drugs are stopped. Monitoring after stopping antithyroid drugs, TSH with cascading within 8 weeks of stopping the drug, then TSH with cascading every 3 months for a year, then TSH with cascading once a year. Most patients with hyperthyroid Graves' disease are rendered euthyroid by 4-8 weeks of treatment with carbimazole, 40 mg daily. TFTs are repeated every 6 weeks, and the dose altered according to the T4 level. TSH may remain suppressed for months despite the T4 coming into the normal range, and is, thus, unreliable. Once the patient is euthyroid, the dose of carbimazole is reduced until the patient is on the lowest amount necessary to maintain the T4 and T3 within the normal range. Remission is usually achieved at 18 to 24 months, after which attempts may be made to stop antithyroid drugs. Minor side effects include nausea and a bitter taste after taking medication. Warn patients to come for FBC if they develop a sore throat, etc., as antithyroid drugs can cause bone marrow suppression. This is seen in less than 0.5% of patients 14. There are 2 potential methods of treating hyperthyroid patients: block and replace, where antithyroid drugs are given with thyroxine replacement, and dose titration, where only antithyroid drugs are used and doses are adjusted to achieve normalization of thyroid hormone production. For both regimes, the remission rate is about 50% if treatment is continued for 6-18 months and then stopped. Titration block regime. The dose is adjusted regularly depending on free thyroxine FT4 measurements. A dose reduction may be needed if the FT4 level falls to low normal or below the reference range, or the TS level increases, indicating the development of hypothyroidism. The aim is to titrate to the lowest dose needed to maintain a euthyroid state. Block and replace regime. The antithyroid drug blocks the synthesis of thyroid hormone. The FT4 level is monitored and levothyroxine LT4 is added in when the FT4 is in the reference range. Adjustments to the LT4 dose are made to maintain FT4 levels in the reference range. In most patients with Graves' disease, a block and replace management regime can induce remission. A systematic review and meta-analysis suggest that both types of methods are equally effective. Furthermore, the dose titration method was associated with a lower rate of side effects. Follow-up. Side effects monitoring. Advise the person to attend for blood monitoring during and after antithyroid drug treatment, radioactive iodine treatment, or thyroid surgery, as advised by their endocrinologist. Blood monitoring may initially be carried out in secondary care, but may subsequently be carried out in primary care. If the person is taking antithyroid drugs, advise them to take medication regularly and to be aware of important adverse effects. If the person is taking carbimazole or propylthiouracil, advise them to seek urgent medical advice if they develop possible symptoms of agranulocytosis or neutropenia such as fever, sore throat, mouth ulcers, febrile or nonspecific illness, bruising, or malaise, and to stop the medication immediately. Arrange an urgent blood test for differential white cell count to exclude agranulocytosis and neutropenia, and consider seeking specialist advice. If the person is taking carbimazole, advise them to seek urgent medical advice if they develop possible symptoms of acute pancreatitis. If acute pancreatitis is suspected on assessment, stop carbimazole immediately and manage appropriately. If the person is taking propylthiouracil, advise them to seek urgent medical advice if they develop possible symptoms of liver disease, such as anorexia, nausea, vomiting, fatigue, abdominal pain, jaundice, light-colored stool, dark urine, or itch. Arrange an urgent blood test for liver function tests, LFTs. If there are significant LFT abnormalities, stop propylthiouracil immediately and seek specialist advice. Two, radioactive iodine treatment. Radioactive iodine treatment induces damage of DNA leading to death of thyroid cells, causing a decrease in thyroid function and/or reduction in thyroid size. It is a first-line definitive treatment for adults with Graves' disease and those with toxic multinodular goiter. Most people with Graves' disease become euthyroid and then hypothyroid within 6 weeks to 6 months after completing radioiodine treatment. People with a large goiter may need high doses or repeated treatments to achieve euthyroidism. Antithyroid drugs should be stopped 5-7 days before treatment with radioiodine because continuous use reduces thyroid iodide uptake and retention, which in turn reduces cure rates. People have to follow radioprotection measures after treatment. For example, close and prolonged contact with children and pregnant women should be avoided for about 3 weeks after standard dose radioiodine treatment. It is contraindicated in people with Graves' disease with active or severe orbitopathy, as it may cause an exacerbation of orbitopathy or de novo development. It is also contraindicated in pregnancy or women planning to become pregnant in the next 4-6 months as it crosses the placenta, and can cause severe hypothyroidism in the fetus. And it is contraindicated in breastfeeding women. Women should be advised to avoid becoming pregnant for at least 6 months after radioactive iodine treatment. Men should be advised not to father children for at least 4 months after radioactive iodine treatment. Radioactive iodine may also worsen eye disease and Graves' thyrotoxicosis. This is more marked in smokers. The patient does have to be informed that the radioactive iodine is cleared via the urine and thus can be passed on. They are usually advised to avoid close contact with children and pregnant women for about 3 weeks. Hypothyroidism is also a potential and common complication. Monitoring after radioactive iodine treatment. TSH, FT4, and FT3 levels should be measured every 6 weeks for the first 6 months after treatment, until the TSH is within the reference range. If the person develops hypothyroidism after treatment and is not on antithyroid drugs, levothyroxine LT4 replacement therapy should be started. If the person remains biochemically euthyroid at 6 months, consider measuring TSH with cascading at 9 and 12 months after treatment. If the person remains biochemically euthyroid 12 months after treatment, consider measuring the TSH with cascading every 6 months unless they develop hypothyroidism. If hyperthyroidism persists after treatment, ensure the person is under specialist care. Thyroid surgery. Surgery is used infrequently in the treatment of thyrotoxicosis. Patients should be returned to the euthyroid state with antithyroid drugs before surgery to avoid thyroid storm. Toxic adenoma or toxic multinodular goiter, which is resistant to conservative treatment or causing compression symptoms, is best treated with surgical excision. Options include total thyroidectomy or hemithyroidectomy for a single thyroid nodule in people to prevent the recurrence of hyperthyroidism with compression symptoms from a large toxic multinodular goiter with a coexisting potentially malignant thyroid nodule who have not tolerated antithyroid drug treatment or it is ineffective, especially in pregnancy or active Graves' orbitopathy. Preoperative treatment with antithyroid drugs aiming for euthyroidism reduces the risk of thyrotoxic crisis, which may be precipitated by surgery. Postoperative complications include hypothyroidism, hypocalcemia due to hypoparathyroidism, often transient, and vocal cord paresis due to damage to the recurrent laryngeal nerve. Patients who undergo surgery will need to be followed up over a number of years, as they may develop hypothyroidism. Monitoring after thyroid surgery. If the person has had a total thyroidectomy, LT4 replacement therapy will have been started post-operatively. If the person has had a hemithyroidectomy, measure TSH and FT4 at 2 and 6 months after surgery, and then TSH once a year for adults, children, and young people.